Hello. Thank you all so much for being out here tonight. So much of the writing process takes place alone, or in my case, when the rest of the world is sleeping. So it's really nice at this point in the process to be able to be out and connect with readers and see people, especially at such a great venue. It's nice to see it kind of come full circle because when I was a graduate student at Emerson, I was here all the time. So it's really nice to be here. So I'm going to talk briefly about the book itself overall, and then read two passages, and then hopefully we'll have some good discussion and answer questions. So, two questions I've been getting a lot lately are why this book and why now? Quite simply, we can't afford to ignore chronic illness. An estimated 133 million patients, as you just heard, live with chronic illness, and by 2025, that number is expected to reach 164 million. Chronic illness is responsible for 7 out of every 10 deaths, as well as 3/4 of all healthcare spending. But it's so much more than that, so much more than the statistics and the economics. Chronic illness is not something, come on down, guys. Chronic illness is not something that happens to other people. The numbers tell us it will happen to most of us, or people that we love, and there are still underlying assumptions and misconceptions about it that are problematic. For example, there is still this idea that people who are sick through their own fault. And we can look at current examples of HIV/AIDS or type 2 diabetes to get a sense of that. And this underlying idea that people with chronic illness are somehow weaker. And this is certainly amplified in the way that we treat women in pain, for example, who are often told that their pain is either in their heads or that they should simply push through it. Scholar and medical historian Roy Porter asserts, disease is a social development no less than the medicine that combats it. This was true centuries ago, when disease was thought to stem from an imbalance of bodily humors and fluids, when infectious plagues were blamed on divine retribution, when people with tuberculosis were shipped off to the sanatorium, or when diseases like multiple sclerosis were considered nervous or hysterical disorders. We will see many instances where, despite the origins of illness, the ways in which society responds to it are not so far apart. In the Kingdom of the Sick is a social history of chronic illness in America, because I found it was impossible to extricate the experiences of living with physical illness from the competing forces of culture, social norms, and technology that surround patients. Inevitably, this became as much a social history of activism as it is a social history of disease, because it was equally hard to tease out advancements in treatment and research from the patients and the advocates who fought so tirelessly for them. It is a chronological book that, for the most part, focuses on post-World War II America, which was a time of, quote, irresistible progress. Between antibiotics and vaccinations, we had more control over acute infectious diseases, and we began to think that we were just one step away from curing everything that ailed us. It was at this point, when we were living long enough that we weren't dying from communicable disease, that chronic disease began emerging as a public health priority. As you heard in the intro, I am a lifelong patient myself, and these experiences informed the writing of this book. I have a rare genetic respiratory disease, primary ciliary dyskinesia, which is a mouthful, so people just say PCD if they can say it at all, as well as other chronic illnesses. I also teach writing for the health sciences at Northeastern, and I chose the book's title from a Susan Sontag quote from an essay that I forced my freshmen to read. Illness is the night side of life, a more onerous citizenship. Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use the good passport, sooner or later each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. So for me, writing this was a sort of blurring of all these different divisions and crossovers as a health and science writer, as a health science writing instructor, as well as a patient. So that's a little bit about the book in the context of that. But from the first passage I'm going to read is from chapter 4. And as I mentioned, this is a chronological book that, after some brief historical background, picks up in the 1940s and 50s. In the early chapters, I explore patient rights, medical ethics, and the various social justice movements of the 60s and 70s, the civil rights movement, the disability rights movement, and the women's health movement, and their influence on chronic illness and modern-day doctor-patient relationships. Of all the major themes in this book, the relationship between gender and illness is perhaps the most compelling or resonant. The shadow of hysterical illness still lingers today, and the "it's all in your head" mentality contributes significantly to delays in diagnosis and treatment of many chronic and autoimmune disorders, particularly in terms of chronic pain conditions. I just talked about all of this on Fresh Air with Terry Gross, and the robust response that continues to pour in shows just how many people are affected by this. For example, women are 3 times more likely to develop autoimmune diseases, and 2.5 times more likely to develop rheumatoid arthritis, 4 times more likely to have chronic fatigue, and 9 times more likely to be diagnosed with fibromyalgia. Not only are they more likely to develop pain, but they are more sensitive to it, and research shows that women are more likely to have their pain dismissed as emotional or psychogenic. When they are treated, it is often less aggressively than men, and women are likely to be prescribed antidepressants, where men would receive painkillers for the same symptoms. Most chapters in the book start with a more introductory narrative segment where patients' experiences set up the context for the history and the analysis to follow. And that's what I'll be reading right now from Chapter 4. In this passage from the Women's Health Movement in Patient Empowerment, you will hear from Alicia Cornwell, a young woman with Crohn's disease, which is an autoimmune disease of the gastrointestinal tract, as well as Melissa McLaughlin, who is another young woman who suffers from chronic fatigue, fibromyalgia, and a host of comorbid conditions. You will also hear from Dr. Sarah Whitman, who is a psychiatrist who specializes in treating patients with chronic pain, as well as Dr. Joe Wright, who is actually an internist just down the road at Beth Israel, who's done a lot of research and writing on the early AIDS movement. So, Alicia Cornwell is a 28-year-old woman living with Crohn's disease. When she first began her diagnostic journey, she was a middle school student with stomach pains. She underwent a variety of tests, from endoscopies to barium swallow x-rays, hopeful that each step would bring her closer to an answer. While the tests and consultations initiated her into the world of patienthood, they also signaled the start of an unfortunate but all too common cycle, dealing with the dismissal of her persistent symptoms. She was told she had reflux disease, but when her problems continued, so did the tension. As the years went on, dismissal took on a more problematic bent, as her physical symptoms were attributed to her emotional problems. At the time, my parents and I were told my symptoms were caused by stress. I heard this for years, right up until I was diagnosed with Crohn's as an adult. In fact, I had heard it so often that until last year I was convinced I was making myself sick because I could not control my life, or even worse, that I was making up my symptoms for attention, she says. The storyline evokes outdated images of emotionally wrought women attended to with smelling salts and placed in darkened rooms, images that are ingrained in historical attitudes towards female patients, hysterical patients. The term hysteria originates from the Greek word hystera, which means womb, and it was once believed that hysteria was caused by the womb wandering through the body. Victorian-era doctors attributed hysteria to an imbalance between sexual organs in the brain. Problems we regard today as associated with hormonal fluctuations were also prominent in the diagnosis of hysteria, notes writer Paula Kamen. The context for this Victorian-era belief reaches back much further in history. As we know, medieval perceptions of women painted them as weaker versions of men, and their monthly cycles were cataloged as evidence that they were mere leaky vessels, inferior to men in ways both physical and emotionally. Unfortunately, this association between hormones and character is one that follows women well past medieval or even pre-modern times. For Alicia, the doubt about her symptoms chipped away at her confidence, which, combined with her age and the accompanying assumption that young people are not supposed to be sick, exacerbated the underlying problems. By the time she entered college,